If you've been following the evolution of medicine and the functional forum for a while, you know that we've been mainly encouraging you to build what we call a micro practice, a low overhead practice that doesn't take insurance, really because insurance and preventative medicine don't make a lot of sense going together, and there are new models available through doing things like direct primary care and packages that make a lot more sense for chronic disease. However, you know, the majority of medicine is on insurance. That's how the majority of people integrate with medicine. And when I had an opportunity to meet Dr. Ornish last week, he told me about how his program was now available on Medicare and some of the other insurance providers. So for particularly those doctors who are new to the evolution of medicine and are still practicing in insurance practice, I believe that this is a way that we can really move the needle on insurance and move the needle on the delivery of integrative and functional medicine into the general population through the Ornish protocol. So we're going to go and speak to Dr. Ornish, find out some more things about his program, ask some interesting questions hopefully about his work and, you know, some of the critics of it and some of his supporters, and we'll see how it goes. So Doc, just first for all of our community, just a big thank you for the persistence that it took to not only, you know, prove that your diet works and your plan works, but also to get this covered by Medicare. I think it's a huge thing. For people who are not completely familiar with the diet and the program, can you sort of give us an overview of the last 30 years?
Well, it's been closer to 40 now, actually. I began doing this work in 1977 when I was a second-year medical student and learning how to do bypass surgery with Michael DeBakey, the pioneering heart surgeon. And we'd cut people open, we'd bypass their clogged arteries, he'd tell them they were cured, and more often than not their bypasses would clog up again because they went back and did all the same things that had caused the problem in the first place. And so that became for me a metaphor of an incomplete approach, that we were really literally bypassing the problem without also treating the cause. And so the guiding principle for me for almost 40 years now has been, what is the cause and how can we address that? And I often show a cartoon of doctors busily mopping up the floor around a sink that's overflowing, but nobody's reaching over to turn off the faucet. And the faucet is, to a large degree, the lifestyle choices that we make each day. What we eat, how we respond to stress, how much exercise we get, and how much love and support we have. You know, when people get put on blood pressure medications or statins like Lipitor to lower their cholesterol, or drugs to lower their blood sugar, and the patient says, how long do I have to take these? The doctor usually says, forever. It's kind of like, how long do I have to mop up the floor? It's like, forever. Well, why don't we just turn off the faucet? And what we've learned using these very high-tech, expensive, state-of-the-art scientific measures to prove how powerful these very simple and low-tech and low-cost interventions can be, is that our bodies often have a remarkable capacity to begin healing, and much more quickly than we had once thought possible, if we treat the underlying cause. And because these underlying biological mechanisms are so much more dynamic than we had once thought, when people make big changes in lifestyle that we recommend, they usually feel so much better so quickly. It reframes the reason for making these changes from fear or prevention to just joy and pleasure, which is ultimately what makes them so sustainable. And so in a series of randomized trials, we were able to show for the first time that even severe heart disease often could begin to reverse by making these changes. The blood flow could improve within just a few weeks. The angina went down by over 90% in the first few weeks. After a year, there was significant regression of even severely clogged coronary arteries, and there was even more improvement after 5 years, whereas the control group got worse and worse. And there was a 300% improvement in myocardial perfusion, or blood flow to the heart, as measured by cardiac PET scans. And we found that there was 2.5 times fewer cardiac events, bypasses, angioplasties, stents, heart attacks, strokes, and so on. We then did a study, a randomized trial, showing for the first time that these same lifestyle changes that could reverse heart disease could also slow, stop, and even reverse the progression of men with early stage prostate cancer, and probably by extension women with breast cancer as well. And we did that in collaboration with the chair of urology at UCSF, Dr. Peter Carroll, and the man who was then the chair of urology at Memorial Sloan Kettering Cancer Center, Dr. Bill Fair. We always try to work with the leading authorities in the field, because when you're trying to do something disruptive, it's nice to work with people who have that kind of credibility. We then found, wondering why these patients were improving so quickly, we wondered what some of the underlying mechanisms might be. And so we looked at their changes in gene expression. And we did this with Craig Venter, who pioneered decoding the genome. And we found that over 500 genes were changed in only 3 months. with the same lifestyle intervention, and in every direction, in every gene in a good direction. In a sense, upregulating or turning on the genes that keep us healthy, downregulating the genes that cause oxidative stress, chronic inflammation, and particularly the RAS oncogenes that promote prostate, breast, and colon cancer were just shut down within just 3 months. It's, again, part of how dynamic these mechanisms are. And then we did a study with Dr. Elizabeth Blackburn, who was awarded the Nobel Prize in Medicine about 5 years ago for her pioneering work with telomeres, which, as you know, are the ends of our chromosomes that control aging. And as they're sometimes likened to the plastic tips on the end of shoelaces that keep your shoelaces from unraveling, they keep your DNA from unraveling. And as we get older, they tend to get shorter, and as our telomeres get shorter, our lives get shorter, and our risk of premature death from pretty much everything goes up proportionate to that. So she had done a study showing that women who were under chronic emotional stress had shorter telomeres, and that when you compared the high stress and the low stress women, there was a 9 to 17 year shortening of their lifespan from the stress. Although what I found most interesting about that study was not just that stress shortened your telomeres, but that it wasn't an objective measure of stress. It was the women's perception of it that determined whether or not it made a difference. So you could have two women in the same kind of life situation, taking care of parents with Alzheimer's or kids with autism, for example. But if some of them were coping with it better, they were meditating, they were eating better, they were exercising, they had more love and support, all the things that we do in our program, it could mitigate and blunt the effects of that so that it didn't shorten their telomeres to the same degree. So I met with Dr. Blackburn and I said, you know, if bad things make your telomeres shorter, maybe good things make them longer. And we found, sure enough, that we actually could increase the enzyme, the telomerase, by just 30% in 3 months, which we published in the Lancet Oncology. And over a 5-year period, we found that the telomeres actually got 10% longer, whereas they got shorter in the control group. It's still the only control study showing that any intervention, including drugs, can actually lengthen your telomeres. And what's so interesting about all these things is that although we tend to think of advances in medicine as being a new drug, a new laser, something really high-tech and expensive, we're using these very high-tech, expensive, state-of-the-art scientific measures to prove how powerful these very low-tech and low-cost and low-tech interventions can be. And, you know, if a new drug came out that could do any of these things, even if it just showed that it could lengthen your telomeres, it'd be a multi-billion-dollar drug. And yet, these are simple lifestyle changes. And that with all this interest in personalized medicine, I think that in some ways personalized medicine can be really helpful. If you're gluten sensitive, that's good to know. If you have pancreatic cancer and you can target an immunotherapy to a particular type of tumor cells, that's a good thing. But in our studies, it was the same lifestyle intervention for all of these. It wasn't like we had a different one for prostate cancer than from heart disease or diabetes or, you know, your genes or your telomeres. It's almost as though if you give your patient the right raw ingredients, they can extract or personalize what they need in order to begin to heal. And there's an emerging field of what's now called lifestyle medicine, which is lifestyle to treat disease and even reverse it, either in combination with drugs and surgery or often as an alternative. And there's a convergence of forces that I think finally make this the right idea at the right time. On the one hand, the limitations of high-tech medicine, drugs and surgery are becoming clear. For example, the randomized trials have shown that angioplasties and stents and the COURAGE study and in 7 other randomized trials don't prolong life, don't prevent heart attacks, don't even reduce angina in people with stable heart disease, which is usually the people who get them. And men with early stage prostate cancer, only 1 out of 49 men actually benefits from chemo or radiation or surgery. And the other 48 often get maimed in the most personal ways because now they're impotent and they can't have sex, they're incontinent, they're wearing diapers for no benefit at huge economic and huge personal cost. Getting your blood sugar down with drugs and the Navigator and the Accord studies in the New England Journal of Medicine didn't prevent the horrible complications of diabetes or the premature death. Getting it down with diet and lifestyle does. And so at the same time that the limitations of drugs and surgery are becoming clear for so many chronic diseases, the power of lifestyle changes, lifestyle medicine, is also becoming clear. And now that with the advent of Obamacare, whatever people think about it, it's really turning all the incentives on their ear. You know, in the past, in a fee-for-service environment, the more operations you do, the more hospitalizations, the more drugs you prescribe, the more money is generated. Now it's more, here's X amount of dollars to take care of someone. You, the doctor, the hospital or clinic, gets to keep what's left over. So keeping people out of the hospital actually now is a much healthier and a much more economically beneficial thing to do. The other thing that's happened is that after 16 years of review, Medicare is now covering our program as a Dr. Dean Ornish program. It's the first time they've covered a lifestyle medicine intervention like that. And as a sign of the times, just yesterday, I was part of a day-long seminar at the American College of Cardiology's annual scientific sessions in Chicago that was organized by Dr. Kim Williams, who's the president of the ACC. And a year and a half ago, he was written about this in MedPage, in Medscape. He found that his LDL cholesterol was too high. He knew all too well the side effects of statins and looked to see if there was a different approach that he could take that involved lifestyle, and came across our work. And he's now been on our diet for many years. He talked about this at the meeting yesterday. And we did a day-long symposium which I was part of, but so were a number of other people. And it was really a first. I think it was a real sea change, a tipping point in cardiology, with it, that the president of the organization could have a day-long seminar on lifestyle medicine. It was thrilling. And ironically, it was in the same room that 10 years ago I debated Dr. Atkins during the ACC meeting. So it just felt like a marker that things have really changed.
So Doctor, you spent so much time proving that this diet works. Why is this just so important to you?
Well, first, it's not just a diet. There are 4 components: the diet, exercise, the stress management, including yoga and meditation, and love and support, or eat well, move more, stress less, and love more. It's really simple in that way. And I thought, before, that if we just did good science, that would change medical practice. And to some degree it did, but not as much as I'd hoped. And so one of the questions was, well, before it was like heart disease can't be reversed, and there's no way diet and lifestyle could do it in such a short time anyway. And so we showed that it could. And then they said, well, you live in California, it's an altered state, this will never play in Peoria. So through our nonprofit Preventive Medicine Research Institute, beginning in 1993, we trained hospitals and clinics around the country, over 50 of them. Prestigious hospitals like Harvard and Beth Israel Medical Center in New York, and Scripps and UCSF, but also community hospitals in Omaha, Des Moines, Columbia, South Carolina, where they told me gravy's a beverage, this will be a big change in our lifestyle, and so on. And we got bigger changes in lifestyle, better clinical outcomes, and even larger cost savings than anyone's ever shown. But it was ultimately disheartening in every sense of the word, because a number of the sites closed down, and they said, this is the best program we've ever had, but we can't afford it because it's not reimbursable. And so the painful lesson for me was that either if it's not reimbursable, it's not sustainable. Unless you go the realm of concierge medicine, or private practice where you charge people a lot of money for lab tests and things like that, which I didn't want this. Having seen what a powerful difference these changes can make, I didn't just want it to be for wealthy people. I wanted it to be for everyone. Yeah. So that set me on a 16-year journey to get Medicare to cover the program, because I figured if Medicare covered it, most of the other insurance companies would as well. And we had the support of Bill Clinton, because I've been consulting with him since 1993, but also Newt Gingrich when he was Speaker of the House. 20 members of the Senate, 30 members of the House, across the political spectrum, heads of the AARP and most of the major organizations, and it still took us 16 years. In fact, I was talking with someone in government recently, they said, only 16 years? When you're trying to do something that's really disruptive, it can be threatening. But I'm grateful to CMS for covering the program. And now that Medicare is paying for it, Anthem, most of the Blue Cross Blue Shield organizations, Aetna and others are also covering it. And so now it's financially sustainable for doctors and so on to cover this. And one of the other good things that they did is that they're not only covering it in hospitals, but they're also covering it in private physician offices at the same level that they do in hospital, as opposed to regular cardiac rehab where it's only paid a fraction in a physician practice as it is in a hospital-based practice. And they created a new benefit category called intensive cardiac rehabilitation, which is 72 hours of reimbursement. Now, most doctors are not really happy practicing medicine these days. The surveys show that most doctors wouldn't recommend medicine as a career for their kids. They're getting bought up by hospitals. They're leaving the practice. Because if you have to see a new patient every 8 to 10 minutes, you don't have time to talk about what's most important. You basically have time to listen to the heart and lungs, write a progress note, write a prescription, you're off to the next patient. It's profoundly unsatisfying for both doctors and patients. It's one of the reasons why more money has been spent out of pocket for the last 30 years for so-called alternative medicine than traditional medicine, because they spend time with you and they talk with you. So we've created a new paradigm of real health care rather than sick care, where Medicare and now most insurance companies will pay for 72 hours of training. And so we divide that into 18 4-hour sessions, and we have a team of people. The physician is quarterback, but he or she works with a dietitian, a nurse, a yoga teacher, an exercise physiologist, a psychologist, and I think that's it, 6 people. and they all work together under the physician's direction. But the physician isn't spending most of his or her time doing that. They just have to be in the office or in the building when the program is being offered. But they can even be seeing other patients or dictate charts or things like that. And by dividing this into 18 4-hour sessions over a 12-week period, it makes it feasible for everyone. So if they work, they come from 5 to 9 p.m. If they don't work, they can come during the day. And they get an hour of supervised exercise, but they also get an hour of yoga and meditation. I mean, who would have thought 10 years ago that Medicare would be paying for yoga and meditation? They get an hour of a group meal with a lecture, and what we call an hour of a support group, but it's really more than, it's not just helping support the other parts of the program. It's not just, exchanging recipes and types of running shoes and things like that. It's really creating a safe environment in which people can be authentic with each other, who can let down their emotional defenses and feel safe and talk openly and authentically about what's really going on in their lives without fear they're going to be judged or criticized or rejected or given glib advice. And that may sound so touchy-feely, and I used to get defensive when people would say, oh, this program is so touchy-feely, and I'd say, no, look at our PET scans and our quantitative arteriograms and our radionuclide ventriculograms and all this stuff. And then finally I said one day, it is touchy-feely. That's what makes it work so well.
Yeah.
We are touchy-feely creatures. We're creatures of community. And so that's why we're getting 85 to 90% adherence to our program after a year. Many doctors think, oh, I can get my patients to take their statins, they'll take their Lipitor. There's no way they're going to change their lifestyle. And yet when you actually look at the data from the pharma company's own results, half to 2/3 of people prescribed any of the statins, Lipitor, Zocor, Mevacor, you name it, are not taking them after just 4 to 6 months, even if someone else pays for them, and even if they don't have side effects. And statins are of proven value in people with heart disease. And the answer is, well, why not? And part of what we've learned over the years is what enables people to make sustainable changes. And it's not fear, it's joy and pleasure and freedom and love. And when you give someone a statin, you're basically saying, take this pill, it's not going to make you feel better, hopefully it won't make you feel worse, to prevent something really awful from happening maybe years down the road, like a heart attack or stroke that you don't want to think about, and so they don't think about it. I mean, for a month or two after someone's had a heart attack or an ER visit, they'll do pretty much anything that their doctor or nurse says, but then they stop doing it because it's fear-based, and fear is not a sustainable motivator. But joy and pleasure and love are. And because these underlying biological mechanisms are so dynamic, when people make these changes, most people find that they feel so much better so quickly. It completely reframes the reason for making these changes from fear or prevention of something bad from happening years down the road to feeling better now. Your brain gets more blood, you think more clearly, you have more energy, you need less sleep. Your skin gets more blood, you don't age as quickly, your heart gets more blood, even your sexual organs get more blood flow in the same way that Viagra works. We found over 90% reduction in the frequency of angina in the first few weeks for someone who can't work or make love with their partner or play with their kids or walk across the street before the light changes without getting chest pain, and within a few weeks they're essentially pain-free. They say, oh, when I do this I feel good, when I do that I don't feel so good. It comes out of their own experience. I came just a few days ago from one of the hospitals we trained in South Bend, Indiana, of all places. It's like if, as Frank Sinatra said, if I can make it in South Bend, Indiana, I can make it anywhere. Yeah. And one of the guys there was on the heart transplant list. And after just 9 weeks, he improved so much in his ejection fraction response and so on with an ischemic cardiomyopathy that he no longer needs a heart transplant. We have several patients like that. It's kind of like, what's the more radical intervention here? Cutting your chest open, having a heart transplant or a bypass, or putting a stent in, or eat well, move more, stress less, and love more.
One of the things that we've had a lot of content on during the Functional Forum and through the Evolution of Medicine has been on this new emerging field of human social genomics and the interaction between people and relationships and how patients interact with each other and how to create good social interactions and how that affects health. How have you sought to deliver that in your program? Or how important has that been in the overall dynamic of your program?
Well, we found that all 4 components are important. We found that overall adherence was correlated directly. The more people changed their lifestyle, the better they followed the program, the longer their telomeres got, the less clogged their arteries became, the smaller their prostate tumors became, the lower their PSA levels came, the lower their blood sugars went, etc. The more you change, the more you improve at any age, which is a really powerful message to give people. In fact, I thought that younger people with less severe disease would do better, but I was wrong. It wasn't how old or how sick they were. It was mainly a function of the more you change, the more you improve. But I think the people that most doctors have the most skepticism about the love and support. They say, I get the diet, got to eat, it's just a question of what, and exercise, you're really doing something. Meditation, I don't know, but there's a lot of evidence now about that. But love and support, so I gave most of my lecture yesterday at the American College of Cardiology's annual meeting to 1,000 cardiologists yesterday about love, which was kind of funny because when I look back of the abstracts over the last 20 years and I put in love, when you exclude the names of people who happen to be named love, there's almost nothing in there on love, even though the heart is the symbol of love. It's like we focus on what we can measure, but what we can measure isn't often what's most meaningful or even what's most important. Albert Einstein once said that not everything that counts can be counted. Not everything that's meaningful is measurable. And when you look at the studies, it's powerful to me that study after study have shown that people who are lonely and depressed and isolated are 3 to 10 times more likely to get sick and die prematurely compared to those who have a sense of love and connection and community. In part because you're more likely to abuse yourself, and in part through mechanisms we don't fully understand. If information's important, but if information were enough, for one thing, nobody would smoke. It's on every pack of cigarettes. It's not like I tell a patient, hey, I want you to quit smoking, it's bad for you. They go, I didn't know that, I'll quit today. It's like everybody knows it's bad for you, and we're drowning in information with Google. But information is not the same as wisdom, and what people, and what's important is that we not just give people information, not just focus on the behaviors, but work at a deeper level. So I'd ask people in our studies, teach me something. Why do you smoke? Why do you overeat? Why do you drink too much? Why do you abuse substances? Why do you spend too much time playing video games? These behaviors seem maladaptive to me. And they'd kind of smile and look at me like, with pity. They'd say, you just don't get it. You don't have a clue. These behaviors aren't maladaptive. They'd say they're very adaptive because they help us deal with our pain. The real epidemic isn't just heart disease or diabetes or cancer, it's loneliness and depression and isolation. The leading prescription drugs after statins are antidepressants. And telling somebody who's lonely and depressed that they're going to live longer if they just change their diet and lifestyle or quit smoking is not that motivating. They say things to me like, I'm just trying to get through the day. Or they'll say, one patient told me, I've got 20 friends in this pack of cigarettes and they're always there for me and nobody else is. You're going to take away my 20 friends? What are you going to give me? Or food fills that void. Or one patient said, fat coats my nerves and numbs the pain, or alcohol or other drugs numb the pain, or video games numb the pain, or working all the time. We have lots of ways of distracting ourselves from our pain. But in our program, the pain is the messenger. It's saying, hey, listen up, pay attention. You're not doing something that's in your best interest. And so when people begin making these changes in lifestyle, and again, because the underlying biological mechanisms are so dynamic, their pain goes away and they feel so much better. They often even say things like, having a heart attack was a good thing, or the best thing that ever happened to me. You go, what are you, nuts? And they say, no, that's what it took to get my attention to begin making these changes. It had made the quality of my life so much better. And they will continue to meet together. These groups are so powerful because many people don't have any place that feels safe enough to really connect on a deep and authentic level. With the breakdown of the social networks, 50 years ago, people had 2 or 3 generations of people in a neighborhood. They had a job that they'd been at for 20 years. They had a church or synagogue or mosque they went to. They had an extended family they saw regularly. And many people don't have any of those things. And when you put them in an environment and you create a sense of safety, it's really powerful.
Doc, one of the things that we talk about at the Evolution of Medicine is the potential for integrative and functional medicine centers to become real centers of health creation in the local communities. How can these practitioners tap into the good work that you've been doing and actually do this on insurance?
Well, when Medicare agreed to cover our program in 2011, we were deluged with literally thousands of requests from healthcare professionals who wanted us to train and certify them in our program. And we're just a small nonprofit. So we spent a year and a half looking for the right partner, business partner, and we settled with a group called Healthways based in Tennessee so that we could focus on the clinical aspects. And the model is that they've been marketing this primarily to health systems and hospitals and so on. I said, let's market it to physician groups. That's who really needs it the most. And also the incentives are completely aligned because if a physician refers a patient to our program in a hospital, there's no economic incentive or benefit for doing that. But if they offer it themselves as part of a physician group, then all the revenue goes directly to them. So it's a way at a time when many physicians particularly cardiologists, are finding their income is being cut back as they're not doing as many stents as they were. They're cutting back on non-invasive testing and so on. Here's a chance to practice the kind of medicine that's really fun. If all we are is a collection of algorithms, we're going to get replaced by an iPhone app. The computers do that better. But I know I went into medicine. I imagine most of the people watching this went into medicine to be healers, not just technicians. And so it gives us an opportunity to create a new paradigm where we spend 72 hours with patients, and yet the physician isn't spending most of that time. It's really fun practicing medicine when you empower your patients with information that transforms their lives and makes them get better and better and wean them off medications in most cases. Again, under their supervision, the physician controls all therapeutic decisions related to the patient, but it gives them the tools and the time and the effort that they don't normally have and the reimbursement to make this viable. So in our model, we train a group of people. Ideally, it should be a physician group of 10 or more cardiologists, or they can be primary care doctors or internists or endocrinologists, but cardiologists especially because they have the largest number of people with heart disease, which is what Medicare is paying for right now. And Medicare will pay for 72 hours of training, and they keep raising the rate of reimbursement. It's now, on average, about $107 an hour times 72 hours is around $7,600 a patient, which is a lot. And the patients come for 4 hours at a time, so they get an hour of supervised exercise, an hour of a support group, an hour of yoga and meditation, an hour of a group meal with a lecture, as we were talking about earlier. And this can be done in their office. It can even be done from after hours when you've already paid for the space and so on. So this is just an incremental cost. And because we do this in groups of 15 people at a time, it's really 15 people times $107 an hour, or over $1,500 an hour. And of course, you don't pay a yoga teacher or a dietitian or an exercise physiologist that much. So it really helps to, if you're doing this as part of an integrative medicine practice, it helps to defray the costs of other interventions that aren't yet covered by Medicare or by other insurance companies. But it provides an opportunity to provide these kinds of services that patients really want, that are incredibly emotionally gratifying for us as healthcare providers to offer our patients, in a way that can actually double or triple your income, and therefore make this much more sustainable in a way that can last and can really be to everyone's advantage. And then because we're collecting data on all the people who go through, it allows us to do large-scale research at a fraction of the cost.
So Doc, one question I have is, how long does it take to get up and running on the program? For say a group of cardiologists that decide they want to run this, how long does it take for them to decide they want to do it until they're running these kind of sessions on a Tuesday night?
Well, our training model is that we train a team of 6 people, and we bring them to San Francisco, and they go through an immersion program for 3.5 days. So they travel on a Monday, they usually get in Monday night. We spend all day Tuesday, Wednesday, Thursday, and then until lunch on Friday. And it's a combination of didactic and experiential. So you go through the program like a patient would, because we've learned the best way to teach it is to really experience it. And then even if you otherwise are healthy, people still feel so much better, and they really understand the nuances of what makes this work as effectively as it does. And they also get lectures from me and others and breakout sessions and the didactic information as well. And then you go back and you start to implement this. We work with you with your payers, we work with you on site, we have rigorous quality assurance and quality control and ongoing education and support. It's a really fun way to do this, and we make this as turnkey as it possibly can be.
You know, I'd be fascinated to know, what are some of the characteristics of the clinics that really make a go of this and are successful with the program straight away?
Well, the clinics that do well are the ones that believe this is worth doing. You know, it's good to have an internal champion that says, yeah, this is something that's really important. This is how I want to practice medicine. This is the medicine of the future. And it's incredibly gratifying as a way of doing that. Healthways takes a small percentage of the revenue that you otherwise wouldn't be getting to provide the training and the ongoing support and data collection and payer support and so on. And so it's something that really works well for everyone.
Dr. Ornish, one of the words you used earlier was convergence, and I think that's a really interesting word. Obviously, here in San Francisco, you've got Singularity University down the road where they're talking about P4 medicine, and that they're coming to that from the technology angle. You've got integrative medicine and your work becoming more and more clear. You've got the functional medicine revolution happening at the Cleveland Clinic and all these areas. What do you see, what's causing this convergence, and how do you feel about this convergence in lifestyle, integrative, and functional medicine?
Well, I'm grateful to be part of it. Let me also mention, I forgot that commercial insurance companies like Anthem, which is Blue Cross Blue Shield in 14 states, including New York and California, are reimbursing this at about 130% of what Medicare is paying. So it's more like $130 an hour times 72 is more like $9,500 per patient. So that makes it even more financially viable. This is really what's happening. I've spoken many times at the Singularity University, their exponential medicine conferences. Daniel Kraft is a good friend who organizes them. And I'm usually I mean, there's a lot of emphasis on technology and quantified self and things like that. And I think those are interesting, but again, information is usually not enough to motivate people to change. It's a great way to bring awareness, and awareness is the first step in healing, and to that extent it can be useful. And certainly as a research tool, it can be incredibly useful. But it's not enough for most people just to be given the numbers and say, here's what's happening. We have to give them the tools to be able to transform what's happening, and that's what we do. Functional medicine, I also have a lot of respect for. I guess what's different is that they spend so many thousands of dollars in doing testing for people that usually isn't covered by insurance. And again, I wanted this to be more for everyone. And I really think that, to me, the fact that we can give people the same intervention, which, by the time you get done with all of your functional medicine testing, there's some fine tuning with are you gluten sensitive or not, and so on. But the most common recommendation that you get in a functional medicine practice is to eat a whole foods plant-based diet, which is really what we're doing anyway. So I think there's information from that. I think Lee Hood is doing some really interesting work as well. But I was on Craig Venter's board of directors of his nonprofit for 4 or 5 years. So I'm really pretty up on what's happening in the genomics field. And this idea, and I chaired Google Health with Marissa Mayer from 2007 to 2009. And we were trying to come up with these very complex algorithms for personalizing a lifestyle intervention for people. And one day I said, we're making this so complicated. First of all, I think at some point as we learn more, we'll be able to personalize things in more detail. But I don't think we're there yet. And to me, I said, let's make it radically simple. And so for reversing disease, this is, I think, what it takes. That's why we were the first to prove that in scientific studies, because most people didn't go far enough. But if you're just trying to stay healthy, you don't have to make such big changes. And what I learned is that, even more than being healthy, people want to feel free and in control. And as soon as I tell somebody, eat this and don't eat that and do this and don't do that, they often immediately want to do the opposite. It goes back to the first dietary intervention when God said don't eat the apple, and that didn't go so well, and that was God talking, and apples are good for you. So I said, look, instead of me telling the patient, here's your diet or here's your lifestyle intervention, which there's automatically pushback, I said, let's do it different. Let's turn this on its ear. Let's say, you tell me what you want to do. And the whole language of behavioral change often has this very judgmental, moralistic kind of shaming quality. And even the language we use, I cheated on my diet, or these are good foods and these are bad foods. And as soon as you call foods good or bad, it's a very small step to saying I'm a bad person because I ate bad food. And at that point, might as well just finish the cheeseburger or the pint of ice cream because you're a bad person. So I wrote a book a few years ago called The Spectrum that was based on the finding that we saw in all of our studies that I mentioned earlier that surprised me, that the more you change, the more you improve at any age. So I said, okay, let's just call foods, instead of saying these are good and bad, I categorize foods from what I call the most healthful, group 1, to the least healthful, group 5. And so what matters most is your overall way of eating and living. So if you indulge yourself one day, it doesn't mean you cheated or you failed or you're bad, just eat healthier the next. You don't have time to exercise one day, do a little more the next. You don't have time to meditate for an hour, do it for a minute. Whatever you do, there's a corresponding benefit. And then you can't fail. It's a much more compassionate approach, because if you go on a diet, generally sooner or later you're going to go off it, and then you have all those toxic emotions of shame and guilt and anger and hostility and humiliation, which really are bad for you. So you can't fail. So then I'd ask a patient, instead of me saying, okay, here's your program, to say, why are you here? What do you want to accomplish? He goes, oh, I don't know, no one's ever asked me that. I'd like to lose 10 pounds, lower my LDL cholesterol 50 points, lower my hemoglobin A1C, get my blood pressure down 10 points, whatever it happens to be. I say, great. What are you doing now? Oh, I'm eating mostly unhealthy group 4 and 5 foods. And how much exercise are you getting? Well, not so much, and not doing much yoga, and not spending that much time with my friends and family and loved ones. I say, so instead of saying, here's your prescription, I say, how much are you willing to change? Oh, no one's ever asked me that. Well, I'm not ready to be a vegetarian, but I'll eat less of the unhealthy group 4 and 5s, the foods that are, red meat and sugar and things like that, and more of the healthier group 1, whole foods, plant-based foods like that. How much yoga and meditation are you doing? 0. How much are you willing to do? I'll meditate 15 minutes a day. How much exercise are you doing? Well, not too much. How much are you willing to do? Well, I'll walk 20 minutes a day. Okay, how much love and support do you have? Not enough, but I'll spend more time with my friends and family. I said, great. We'll support it, we'll track it, and after like 4 to 6 weeks, we'll measure it again and say, okay, look, you've lost 5 pounds, you wanted to lose 10, your cholesterol's come down 30 points, you wanted to come down 50, and so on. Just go a little farther and you can get the rest of the way there. It doesn't mean you have to eat this way all the time, but to the degree you move in that direction, you're going to look better, feel better, lose weight, and gain health.
So, Doctor, we ask our community, to come up with some questions that they would like to ask you. And one of the major things that comes up, and the most controversial area of your work in that is the diet, out of the 4 parts of it, and the nutrition. What do you eat? And what would you say to sort of detractors of your work that would say that the nutrition is just one part, but the actual health effects are coming from the other 3 parts, the meditation, the exercise, and the love and support, and they're causing the majority of the effect, and the diet is still stuck in the 80s methodology of low carbs?
Well, first of all, we've actually done analyses where we correlated not only the adherence to the overall program with changes in the arteries, but the adherence to the diet and changes in the arteries. And we found at both 1 year and at 5 years, there was a highly significant statistically significant correlation between adherence to the diet and changes in their arteries across both groups. So we know it's not just one, it's the diet's very important. There's a whole literature on everything from animal studies, epidemiological studies, in randomized trials that has shown that. There was a wonderful article by Stephen Smith in the New England Journal of Medicine a few years ago that showed what happens to your arteries on different diets, not just to your risk factors like cholesterol, blood pressure, and weight, and so on. It's worth pointing out that we still have the only randomized controlled trial data showing that any dietary intervention can reverse heart disease. Now, if other people want to show that a paleo diet or other things like that, an Atkins diet can reverse heart disease, I will be the first to welcome them, but no one has shown that. And what this article in the New England Journal of Medicine showed that on a whole foods plant-based diet that's also low in refined carbs, the arteries are essentially clean. On a standard American diet, they're partially clogged, and on an Atkins type, paleo type, high protein, low carb diet, high fat diet, they're severely clogged. But what was most interesting is that it's not always reflected in the usual risk factors like cholesterol and blood pressure. I mean, people have done studies comparing an Atkins diet and an Ornish diet. They'll say, well, you lose weight on both diets, so pick the diet you want. Or they'll say, well, the HDL goes up more on the Atkins diet, the LDL goes more down on an Ornish diet, so it doesn't matter. Tell your patients to eat what they like. But what happens in your arteries is very different. We've shown through thallium scans that blood flow to the heart improves in just a few weeks, that with cardiac PET scans, there's a 300% improvement in blood flow. Using quantitative arteriography, these are the state-of-the-art measures. There's some reversal after 1 year and even more reversal after 5 years. And 2.5 times fewer cardiac events. If anyone else has a better diet and they can do in randomized trials that it shows reversal of heart disease, I would be all ears to hear that. But no one has done that yet. The only diet that's been shown to do that in our work and other people's work as well has been a whole foods plant-based diet. Now, there's like I said, it's never just a low-fat diet. As I mentioned earlier, I debated Dr. Atkins and people like him many times in the past, and he was the low-carb guy, so I got pegged as the low-fat guy. It's never been about just fat. Fat is just one of many constituents that relate to our diet. It's low in the bad carbs, the bad fats, and the bad proteins, and it's high in the good carbs, the good fats, and the good proteins. So I've been adding fish oil to our diet since 1984, 1983, because my mentor when I was doing my training at Harvard Medical School and the Massachusetts General Hospital was Alexander Leaf, who was the chair of medicine there. He then became the first chair of preventive medicine at Harvard, and he did a lot of the pioneering work with fish oil. So I've been recommending omega-3 fatty acids longer than most of the other people in functional medicine and others. But not a lot of fat, just you only need about 4 grams a day. More than that doesn't give you any extra benefit. There was and it's not just fat versus carbs. The diet that I recommend is a whole foods plant-based diet because there are literally hundreds of thousands of protective substances in fruits and vegetables and whole grains and legumes and soy products, from phytochemicals, bioflavonoids, carotenoids, retinols, isoflavones, genistein, lycopene, that have anti-cancer, anti-heart disease, and anti-aging properties. And they are naturally low in fat and naturally low in refined carbs. This has always been the diet that I've recommended. Now, More recently, we've added nuts and seeds to even the reversal diet because there's enough evidence out there that I was impressed by that. And I think that it's not even because of the fat, but I think there's just the germinal quality of nuts and seeds. It may sound a little unscientific, but the regenerative, seeds and nuts are all about creating the life force, if you will, the chi, the shakti, whatever name you want to give to that. I think is powerful, and there's certainly enough scientific studies showing that they're beneficial that we've added them. This is not a Sermon on the Mount. When studies come out that show that they work, we include them. But on the other hand, when you look at things like the Mediterranean diet, there was an article in the Predimed study that came out a couple of years ago in the New England Journal of Medicine. The headline was, Mediterranean diet better than low-fat diet at preventing heart disease. Well, if you actually look at that study carefully, the control group was on what they call the low-fat diet, went from 39% fat to 37% fat, hardly any reduction at all. They replaced fat with sugar, which is never a good idea. And if you actually look at the outcome data, they didn't show a significant difference in cardiovascular events. They showed a reduction in stroke because the omega-3s help to prevent blood clots from forming, that thrombus is usually what causes strokes. But it was only when they pooled the stroke data and the cardiovascular data that they showed a reduction. When they only looked at the cardiovascular data in isolation, there was no significant difference. So the Mediterranean diet is a better diet, but it doesn't go far enough to actually reverse disease in the same way that what we're doing does.
Now, Doc, I know that you've been completely focused through your career on the heart as the organ of specialty. If you had been focused on diabetes and type 2 diabetes, do you think the recommendations in your program would have been different?
Well, it's not what we feel. We published a paper in the American Journal of Health Promotion on almost 3,000 patients who went through our program in 24 sites in West Virginia, Nebraska, and Pennsylvania, 3 of the more challenging parts of the country. Yeah. And we showed significant reductions in every metric, not just LDL, but also in hemoglobin A1C and in blood sugars and so on, and triglycerides and such. One of the things that's been repeated so often, it's almost become a meme, even though it's not true, is that Americans have been told to eat less fat, they're fatter than ever, low fat is dead, we should eat more fat. Well, it's true that Americans have been told to eat less fat, but I went to the U.S. Department of Agriculture database to say, what are we actually eating? Not what have we been told to eat, but what are we actually eating? They track the entire United States food supply every decade since 1950. So they know exactly what the country as a whole has been eating. And what I learned is that we've actually been, every decade since 1950, we've been eating more fat, more sugar, more calories, and more meat. 67% more calories, for example. So not surprisingly, 67% more calories. So not surprisingly, we're fatter, not because we're eating too little fat, we're actually eating more fat than ever, but because we're eating too much of everything. And so I think it's really important for people to understand that it's not this reductionistic thinking of, it's all low fat or it's all low carb or whatever. It's not. First of all, it's not just fat versus carbs. An optimal diet to me is low in both because fat has 9 calories per gram, protein and carbs have 4. So when you eat less fat, or put another way, if you eat lower fat, you can eat the same volume of food, but you're getting a lot fewer calories because the food is less dense in calories. Also, there was an important article that came out a couple of years ago in Cell Metabolism, and others have shown that as well, that it's not just fat versus carbs, that animal protein itself is harmful. They found that people who ate a lot of animal protein, that there was a 75% higher risk of premature death from all causes, a 400% increased risk from type 2 diabetes, and a 500% increased risk from all cancers. So independent of the whole fat versus carbs. Walter Willett and his group at the Harvard School of Public Health published a meta-analysis of hundreds of thousands of people and found that people who ate a lot of red meat had higher rates of cardiovascular disease, stroke, the most common forms of cancer, prostate, breast, and colon cancer, and type 2 diabetes. I wrote the editorial that accompanied that. It was called, I think, Holy Cow or something like that. So there's a lot of evidence out there. There are people out there who are really obfuscating this, most of whom aren't doctors, occasionally some who are, who should know better. That's a great way to sell books by telling people what they want to hear. But, red meat, they'll say, oh, well, it's grass-fed beef is good for you. Regular beef is not. There's not a shred of evidence to show that. It sounds good. It may be true. But no one has ever shown that people eating grass-fed beef get less heart disease or other conditions. The only thing they've shown is it's a little bit higher in the omega-3 fatty acids, but there are a whole lot better ways of getting omega-3s than eating a slab of beef. So I'd love to be able to tell people that, red meat is good for you, but it's not. It's just the way it is. Now, Should you never eat it? I'm not saying that either. If you don't have heart disease and you're otherwise healthy and you have it on occasion or use it as a condiment, it's probably not a big deal. But if you're trying to reverse a life-threatening condition, the pound of cure rather than the ounce of prevention, what we found is that the more you change, the more you improve. And if you want to get reversal, it takes a lot of change. But the good news is that we're getting 85 to 90% adherence to our lifestyle intervention after a year in all of the many sites that we've trained, even though the training program is only 12 weeks long.
Doctor, one of our goals here at the Evolution of Medicine is to move more doctors across, to move doctors from traditional medicine into integrative, functional and lifestyle medicine. What would you say to those doctors who are currently on the fence, who haven't made it across, to encourage them to make it on this journey?
Well, it's a very powerful way of practicing and a very emotionally gratifying way of practicing medicine for both the providers and for the patients. And this integrates very well into functional medicine practice. There's nothing here that is at odds with functional medicine. Rather, it's a synergy of the two. Integrative medicine, it is integrative medicine. President Clinton appointed me to this White House Advisory Commission on Complementary Alternative Medicine Policy. President Obama appointed me to this White House Advisory Commission on Integrative Medicine and Public Health and Prevention. It is an integrative medicine. It is preventive and public health medicine. But the nice thing about it is what's different from these other things is that it's reimbursable at a very high level. And so that provides a sustainability that enables you to offer, say, integrative medicine approaches that aren't yet reimbursable by Medicare or by insurance to make your practice more financially viable and sustainable. And that's the painful lesson that I learned many years ago, that if it's not reimbursable, it's not sustainable. And now it is. And so this is my life's work. This is what I want it to be our life's work. This is our mission where we can work together to create a whole new paradigm of healthcare that brings in, no one has a monopoly on truth, including me, especially me. But we can all work together and find ways of continuing to advance the field and evolve the recommendations, do high quality research so we can really be of best service to our patients, which is really what it's all about anyway.
So doctor, just one last question, and this is really for me, this is not necessarily for our community, but I would just wanted to know, I see more and more countries around the world and big organizations and countries that are looking to cut costs and are looking to deal more effectively with non-communicable diseases. There are these other countries that aren't as far along with integrative functional medicine in their communities. What would be your recommendation to governments, people high up making decisions about how to really reduce healthcare costs from non-communicable diseases?
Well, those are important questions, and I've given a lot of thought to them. And I was in Dali in China last fall for the World Economic Forum, lecturing at their annual meeting. And what's so sad is that we were in China, the rate of these chronic diseases in China was a fraction 50 years ago as it is now. But unfortunately, so many countries are starting to eat like us and live like us, and now all too often die like us. And it's all completely preventable. It's all happened in the last generation or two. And so, and the irony in all of this is that the diet they were eating before they copied the American diet and lifestyle was the one that we found that can reverse and prevent all these conditions. It's essentially a third world diet. And so I've been working with leaders around the world to help them understand that. I've met several times with Prince Charles in the UK and the ministers of health there because they're at a point now through the National Health Service that if they start cutting, they're scheduled to go bankrupt in a few years, and if they simply just do more of what they're doing, then the only option they're going to have is to ration, and that's politically unfeasible. But here, we found in our studies that Mutual of Omaha did a very carefully controlled study and found they saved almost $30,000 per patient in the first year. Highmark Blue Cross Blue Shield found they cut their overall healthcare costs in half in the first year. And by 400% in that subgroup of people that they'd spent at least $25,000 on in the previous year. So these are not only medically effective, but very cost-effective interventions. And if you take an even broader perspective, so often people say, what can I do as one person about these major issues of global warming or, healthcare costs or energy use or things like that. And it turns out that one of the most powerful contributors to global warming is livestock consumption. More global warming is caused by livestock consumption, more greenhouse gases are emitted than all forms of transportation combined. It's why Al Gore became a vegan, even though his family's a cattle rancher, because he realized you can't just talk about light bulbs and smaller cars if the major issue is what we eat. And part of what I've learned is that if it's meaningful, then it's sustainable. And if you understand that something as primal as what you eat every day is not only good for you, but good for the planet, It imbues those choices with meaning, and if it's meaningful, then it's sustainable. It doesn't mean you have to be a vegan, but even if you have a meatless Monday, to whatever degree you cut back on animal protein, particularly red meat, it's not only helping you, but it's helping the planet as well. And it takes 10 times more resources to eat a meat-based diet than a plant-based diet. There's enough food to feed all the hungry people in the world today if more people ate a plant-based diet. So again, I think that there are the people who say we should be eating more red meat and grass-fed beef and things like that. In addition to the fact that it's not true from a health standpoint, it's definitely not true from a planetary standpoint. And when people understand that these choices that we make each day, for better and for worse, are imbued with meaning, it makes those choices, the good choices, much more sustainable.
Doctor, just a warm thank you from our community. Thank you so much for all the pioneering efforts that you've done in order to be able to make this scientifically credible, to get lifestyle medicine to be available on health insurance, both Medicare and all these other insurances. I think it's a massive step forward.
I was in Texas recently where I grew up, and somebody said, oh, this is pioneering, like you're saying, and somebody else said, yeah, you know how we tell pioneers in Texas? By the arrows in their backs. I said, yeah, I've had a few. But thank you for making this available to people. I'm really grateful.
Thank you so much from our community, and if there's anything else, if you ever want to speak to the functional and integrated medicine community in the future, we'd love to have you on the show and share some of your work, so thank you so much.
If anybody's interested in learning more about our work, just go to our website, ornish.com. Everything on there is free, but there's also a section on there if you're interested in learning more about this. We'll be happy to contact you, and I look forward to that. Thank you.
So that was a lot of fun. Hope you enjoyed it. Thanks so much for tuning in. We'd love to get our feedback from our community as to what you thought of the interview, what you think of Dr. Ornish. Have you tried running Dr. Ornish's protocol? Are you interested in running it? The thing that I'm struck with every time that I go and meet these healthcare luminaries, people who have been pushing forward medicine for decades, I'm just always struck by the quality of character, the heart that they show, their love for what they do. I think they're just interested in taking medicine and humanity forward, and it's always refreshing and inspiring to spend time with them. And it makes me very thankful for our community and what I think we're capable of doing. As I started at the beginning, this is available on Medicare. This is an access point for doctors who are just wanting to come into integrative and functional medicine for the first time. And this is an access point where you can still bill insurance. You can get paid the same as if you're working in a group system or hospital system. I think it's a very exciting opportunity, and really glad to have been able to document it. Thanks so much for watching, and we'll see you next time.